To be honest, I'm very, very excited. And I want to tell you the next minute something about the diagnosis of fetal facial clefts. So with an incidence of about 2 in 1,000, fetal facial clefts are one of the most frequent congenital malformations. So it's very useful to be able to handle them. The prenatal diagnosis is very important to prepare parents in order to avoid traumatic situations after birth. And furthermore, the correct diagnosis of the involved structures helps counseling the parents regarding the further treatment after birth. So, what are the tools we need for correct diagnosis of fetal facial clefts? You see these 4 planes. And with these 4 planes, you are able to make a correct diagnosis of all fetal facial clefts. So the first one, that's the coronal frontal section with the depiction of the nostrils, the tip of the nose, the upper lip, and both lips. So, and in this view, normally it's not so difficult to find defects here of the upper lip. And when you find a cleft lip, so the next step has to be the assessment of the alveolus. And for this, you have to get an axial plane, you see here, the alveolar ridge with the alveolar cavities. This here, inside the foramen, you see here the fusion lines. The fusion lines are between the incisors and the cannon tooth. And this whole segment with the median part of the lip and the incisors, it's called the premaxilla. This one is the primary palate. And the incisor foramen is a border between the primary and the secondary palate. So the clefts in the alveolar ridge you have to find here, between the second incisor and the canine tooth. So, when you find a cleft now here, so then the problem starts. And the problem is here, this black hole. The problem of the assessment of the palate, the most common problem are the surrounding osteostructures causing shadowing artifacts and avoiding the assessment of the palate. 2 other points are the dome-shaped structure of the palate and the fact that hard and soft palate are not in one plane. So, what to do? So, the good news, actually, it's not so bad, because it's not really necessary to visualize the whole palate. Because the defects of a palate lie in the midline, it's enough to see the soft palate in the midline to find out whether the palate is closed or not. When you make this diagnosis, you have to be very, very careful with the intonation angle. Okay, you see here a profile, and I'm changing the intonation angle. If the sound comes more from above, I wait a moment. Now the sound comes more from above. Then you have here shadowing artifacts. You can't see the palate. Now I change the intonation angle. So more coming from below. Then the soft palate appears here. Okay? So what you have to do is you have to use the window between the both jaws. And then you can clearly identify here behind the tongue the soft palate here with the uvula. I want to focus here a little bit on the position of the tongue. I come back to this later. This one here is the normal position of a tongue. You see the tip of the tongue between the jaws behind the upper lip. And here is this pharyngeal space is wide open to hold the airways open. So I want to be honest. When you want to make this diagnosis, you have to train this view very extensively. You will not be able to diagnose this cleft palate if you are not 100% sure in detecting the normal conditions. That's very, very important. So this view isn't, to get this view can be very difficult, so it would be helpful to have other indicators for routine diagnosis that can indicate that this fetus has a cleft palate. So the challenge is with which fetus might have isolated cleft palate. So we have two indicators for this. So this one is a schematic representation of a coronal view in this plane in the 7th week of gestation. You see here the nose septum, you see the palate plates of both sides, and so you see the tongue here. The first step is the tongue has to sink down. Then the palate plates can straighten up, and then the closure of the palate can start. So that's why the sinking of the tongue is what depends from the size and the growth of the mandibula. That's why fetuses with smaller mandibulas often have disturbed closure of the palate. So one of the indications is microretrognathia. All fetuses with microretrognathia are suspicious to have isolated cleft palate. But that's not all, because you see here different profiles from children with isolated cleft palate. You see here severe microretrognathias, but you see here profiles they're quite normal. You wouldn't expect a cleft, so another indicator would be helpful. And there's one, and the key for this is the uvula. Why the uvula? So the closure of the secondary palate always works in the same way. That's very important. Always always works in the same way. It starts at the incisive foramen and goes continuously in the dorsal direction. Imagine this like the closure of a zipper. This one is the closure of the palate. So the completely closed zipper are the normal conditions. The almost completely closed zipper is the mildest form of isolated cleft palate, the uvula bifida, and so on. And the wide open zipper is the cleft of hard and soft palate. So this means the uvula is the always affected structure in all cases of cleft palate. So the other way around, that means a normal uvula rules out a cleft palate. So, and you see the defects always lie in the midline. So, how to visualize the uvula? There are two approaches. So the first one starts with a horizontal plane here. That's a plane you measure the head and you check brain structures. And from this plane, you move the transducer parallel to this plane in the caudal direction. Then here opens the pharynx. You come to the soft palate and the uvula. Sometimes you have to move the transducer a little bit to find the uvula. That's here in the ultrasound, the horizontal plane. So I move the transducer in the caudal direction. Then here in the center, it opens the pharynx. And then you see here this structure. And because of its typical echogenic pattern, we called it the equal sign, because it looks like an equal sign. The other approach is from a coronal frontal section, you can see here. So you move the transducer also in a parallel to this plane. Then you come here in the pharynx. You can orientate in the larynx and the epiglottis. Sometimes you have to search here the pharyngeal space. This is this approach. You see here, larynx, epiglottis, and here also the equal sign. So that's the point in routine examination. If you see the equal sign in this way, you can be sure that the palate is intact. But please remember, we speak about an indicator. So the absence of the equal sign doesn't prove a cleft palate. It's only an indicator that it could be. And in this case, you have to examine the palate in the mid-sagittal section. I'm too fast. So I want to show you here some examples. This was a fetus. It was a completely unremarked fetus. I found nothing, no other defects. So, and you see here, I'm searching the coronal section through the pharynx, and I search here for the uvula. Huh? You see here the tongue. I go back to the pharynx, and I'm searching here in the pharynx for the equal sign, but I couldn't find the equal sign. So this is the indication it could be. So the next step is to the assessment of the palate in the mid-sagittal section. And then you see this here. Okay? These are the normal conditions, and this is our child. And you can clearly see here. Here's the soft palate with the uvula, the tongue, and the wide open space of the pharynx. You see here the absence of the soft palate and of the hard palate here. And but what we see in this case here, a normal position of the tongue. That's very important for the postpartum treatment, because not all fetuses with isolated cleft palate have a glossoptosis and a respiratory problem after birth. So it's more a function of the mandibula. And if the mandibula is quite okay, and the position of the tongue is okay, so you haven't to expect a respiratory problem after birth. Okay? But you have surely, very clearly, an isolated cleft palate. You see here, after birth, this was the palate, the hard, and the soft palate. So, next example. There was not such good conditions. The BMI was higher, and I want to show you that it made function too. Okay, I'm searching here in the pharyngeal space for the equal sign, and I cannot find the equal sign. It was an unremarkable fetus too. So, next step, assessment of the palate in the midline. And then you see here the following situation. Here you can see a part of the palate. Here, see, you can see it? Part of the soft palate, but it's markedly too short. And it doesn't end with the uvula, you see here, the normal conditions. Okay? So in this case, we made a diagnosis of an isolated cleft palate only of the soft palate. Okay? And you see here the picture postpartum. Okay? So you see, you can detect isolated cleft palate only in the soft palate too. So here we have another indicator. That's not a normal profile. Okay? You can see a markedly micro retrocracia. So in this case, I don't search for the equal sign, because I have an indication that it could be because of the micro-retrognathia. So the next step to check the palate in the mid-sagittal section. And then you see here this situation, okay? So it's more difficult to differentiate because the tongue is very, the pharyngeal space very narrow, and the tongue is lying very deep here. You see, there's no space between the posterior wall of the pharynx and the tongue. But you can see it. If you are trained, you can see it, that there is no soft palate behind the tongue. When the child is drinking and moving the tongue, look here. Okay? You can clearly see it. Okay? So, but this isn't totally other situation. You have surely an isolated cleft palate, but here I want to focus on the position of the tongue. That's a very abnormal position of the tongue, you see? The tip of the tongue is lying here. Normally, it's lying here. And the space between the posterior wall of the pharynx and the tongue is very, very narrow. So this is very important for the clinical situation because you have to expect respiratory problems after birth. And it can be very, very difficult to treat such children after birth. So you see this here after birth. That's a device especially for these children with such a plate to avoid the glossoptosis. And it can be very difficult to make such a plate here. So that's a situation for a special team. And it's very, very useful to know this after, prenatally. So, and here 2 examples. So you can you can use the assessment of the palate for the diagnosis in cleft lip palate. Okay, you see here the frontal corona section with this cleft on the side, unilateral cleft of the lip. So what is the next step? The next step is to check the alveolus. No, the alveolus. In this case, is lip, the next structure, alveolus. Okay? So, the axial plane with the depiction here of the alveolar ridge, and here you can clearly see the defect of the alveolar ridge. And the next structure, palate. So, the midline, tongue, and you can clearly see here the absence of the soft palate in the midline. So the correct diagnosis of this is unilateral cleft lip, cleft alveolus, and cleft palate. Remember, in cases with cleft lip palate, you never see glossoptosis because the glossoptosis is a function of the growth of the mandibula. So in these cases, you don't have to expect any respiratory problems. Okay? So another case, you see again a unilateral cleft. Next step, check the alveolus. So here the axial plane. And you see here, between the incisor and the canine tooth, you see here the smaller defect. And then the next step, to check the palate. And here, we can see here the tongue, and we see clearly behind the tongue, the soft palate with the uvula. So here, the correct diagnosis is unilateral cleft lip, cleft alveolus, but intact palate. And that makes clinically a very big difference because the problems after birth with hearing, speech, and so on is a problem of the cleft palate. So this situation is for the parents very good because they know, okay, we have we have fewer problems. Okay, it's a better prognosis.
As one incisor must be genetic syndrome, or not? One incisor,
No, it's not one incisor. You have, in this case, I think you have the two incisors, because the cleft is very, very small, okay? But it's not a syndrome from one incisor. Sometimes the second incisor is not there, but not in all cases. And I would expect in this case with this small cleft, that likely the second incisor is present, okay? So this is a postpartum picture. You see here the cleft of the alveolus and the cleft lip. So thank you for attention. I would be very happy. So the head here is lying down, okay? Here we have the back here on the left side. And the head is here, okay? Now we have to focus a little bit. Okay, so here we are in the plane to measure the head. We have the falx, thalamus, cavum, septi pellucidity. Now I move the transducer in the caudal direction, cerebellum op. Okay, now we have the situation that the head, I can see it here, that in this position the head is flexed because you can't see any fluid here inside the pharynx, so the head is surely flexed here. That's a bad position for this. So now here you see it. Okay? Here? Yes? It's not much fluid, but it works too. And you see here clearly the equal sign. So this is the step in between a diagnosis. You say, okay, the palate is intact. So here you can finish your diagnostic regarding cleft palate, okay? So you see here, now it's very bad position, okay? So, können Sie sich mal auf die linke Seite drehen? So, we try to speak with the child. Und kommen Sie ein bisschen zu mir rüber. Okay. So, I try to get here a frontal coronal section. Okay. So, the arm in front of the face. Okay, so now a little bit better. Okay, so here we have the depiction of the lips, upper lip, nostril, and we see clearly the lips are intact. There's no problem with the lips. So, and if you have these features, okay, if you have seen the equal sign, and you have seen closed lips, so it's sure that there's no defect. But you haven't to search for defects only of the hard palate or only of the alveolus. That doesn't exist. If the system is closed in the region of the uvula and in the region of the lips. The rest is closed too.
Is there anything you would like to see from the audience?
So,
I think everybody's deeply impressed.
sorry?
I think everybody's deeply impressed watching you scanning, and it looks so easy.
Yeah, it's not so
There
so
it is.
hard. It's not so hard. You see here now clearly again the equal sign. It's not so hard. It's a question of training. Okay, it's very important. I said every time it's very important to train it. You can't use it if you need it in situations you have suspicious findings. You have to do it over months with every fetus you see in this age of gestation. You have to be very, very sure with the normal conditions, okay?
Thank you very much, Lucas. Thank you.
Okay, one moment.
Okay.
One moment here. We have a chance, okay? Ah, yes. Okay, the mid-sagittal section, there. Oops. Okay. When you are trained, you have seen it yet there, okay? But that's a question of training. So sometimes you have just a few seconds to see it, and then you have to be sure that you have seen it, okay? So, but this is a good situation for the alveolus. You see here, the axial plane. Oops. Here, okay. The alveolus,
Wonderful.
alveolar ridge, okay? And these are the points you have to search for the clefts. This one is the canine tooth, and here are the two incisors, okay?